Now stay with me for a few minutes and let's really kind of dig a little bit deeper into the renin-angiotensin system. And we're going to throw this big thing at you here. And you're like, oh my gosh. Okay, so let's start up here. So this is our renin-angiotensin aldosterone system. What's going to kick this into gear? We have a drop in blood pressure and or a drop in fluid volume. So my blood pressure drops. My kidney is going to go, oh shit, and release some renin. My liver is going to be like, oh shit, and release some angiotensin, um, or excuse me, angiotensin. Those are going to act on each other. Renin is going to act on the angiotensin and form angiotensin 1. Well, the lungs are like, I don't want to be left out. So lungs are going to release angiotensin converting enzyme. That's going to interact with your angiotensin 1, turn angiotensin 1 into angiotensin 2. That's real important because angiotensin 2 is your vasoconstrictor. So my blood pressure has dropped. I've gone through a few steps with my kidneys, my liver, and my lungs. And now I've got angiotensin 2, which is a vasoconstrictor. That's a good idea when my blood pressure drops for my body to try to maintain cardiac output. So angiotensin 2, if we keep following this down the line, is going to act on the adrenal gland down here, stimulate release of aldosterone. And your aldosterone is then going to go back to your kidneys. So we kind of started with the kidneys, and we're going back to the kidneys, and kidneys get aldosterone back to them, and the aldosterone tells your kidneys to reabsorb salt and reabsorb water. So I've got vasoconstriction going on, and I've got fluid retention happening when this renin-angiotensin aldosterone system is activated. So when we're talking hypertension, we can kind of play around with some of this to drop blood pressure using this system. In point here, very commonly prescribed are ACE inhibitors, are angiotensin converting enzyme inhibitors. All these end in pril, so you'll see lisinopril, it's very commonly prescribed. Enalapril, another very commonly prescribed ACE inhibitor, also known as Altase or Vasotec, if you see those trade names out there. But lisinopril, enalapril, anything ending in pril is going to be an ACE inhibitor. And what do ACE inhibitors do? Well, they inhibit the actions of your angiotensin converting enzyme. So remember, we've made angiotensin 1. That's going to be converted into angiotensin 2, which is a vasoconstrictor. So if we inhibit that converting enzyme, we are left with angiotensin 1. We don't make that vasoconstrictor. So in turn, we don't have systemic vasoconstriction. We've got a little bit of vasodilation, and we can lower blood pressure. And we can also play with angiotensin in a different way. So we have angiotensin receptor blockers, or ARBs, or ARBs. Any of your sartans, your losartan, valsartan, also seen as Cozar, Benicar, Diavan, as their trade names. These are angiotensin receptor blockers. So instead of blocking the converting enzyme and blocking conversion from angiotensin 1 to angiotensin 2, we do have that conversion. So we do have angiotensin 2 present, but now we're blocking the action of that angiotensin 2. So we do have it out there. We have angiotensin 2 out there, which is a vasoconstrictor, but we're blocking the receptor sites for it. So it can't do anything. It's just kind of freely floating out there, right? So we can do this in one of two ways. We can inhibit our converting enzyme, so angiotensin 1 doesn't even turn into angiotensin 2. Or we can let angiotensin 1 turn into angiotensin 2 and be just fine with it, and then block the angiotensin 2 receptor sites. And the end result is the same. Blood pressure goes down. We are affecting that renin-angiotensin aldosterone system, and we're happy about it. Except we're kind of going about it in two slightly different ways. Your ACE inhibitors, your angiotensin converting enzyme, we're inhibiting that, so we're blocking the production of angiotensin 2. With our angiotensin receptor blockers, or ARBs, or ARBs. We are blocking the action of angiotensin 2. So here, angiotensin 2 has been created, right? Because we have those converting enzymes to create angiotensin 2, but now we're just blocking the actual action of that angiotensin 2 and not getting vasoconstriction. Very quickly and very important is one of those kind of oh no side effects of ACE inhibitors and angiotensin receptor blockers, ARBs. That is angioedema. You see this not uncommonly with these drugs, and your patient will be on this medication. All of a sudden, their tongue swells up, like this picture here. You're like, oh my gosh, what do I do? It looks like a big old allergic reaction, and we're going to treat it as such because it's a type of allergic reaction, and hit them with that epi, hit them with that Benadryl, hit them with that local protocol, whatever you're following. But this is I wouldn't call it a common side effect, but it's not an uncommon side effect to these medications. So if you see facial swelling like this, especially swelling of the tongue, that's angioedema, and if they're on an ACE inhibitor or an ARB, that should be setting off some flags in your head that says they are having this effect to this medication.